Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit OIEBroadcasting.com and sign up today.
Welcome back to part 2 of my interview with retina specialist Dr. Walid Mangal. In this episode, Dr. Mangal discusses treatment of specific retinal states. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Now, there's some information in the literature that the MicroPulse laser actually reduces VEGF. If you could comment on that.
Yeah, so it's alluding to the point I made earlier, you know, the changing in our thinking as it comes to lasers. It went from, could it increase oxygenation? Well, that's been false. So, it's been decades since that theory came about and there's been no evidence for it, and, maybe the scar is what's leading to it working. Well, we know that's false too. So what laser really does is that it releases inhibitory cytokines. It releases chemicals that are inhibiting VEGF. Basically, it's causing the cells, the RPE cells in your retina, to release anti-VEGF chemicals that's inhibiting the growth of VEGF in the eye. So that's how laser works, and that's probably how MicroPulse also works.
And I think it also restores the Macular cells, the glial cells in the retina. The Macular cells, those glial cells, are very important for the blood retinal barrier. It helps enhance the blood retinal barrier.
That's right. Yep. Yeah. I mean, they see that now in those histological studies that I was referring to. They can see that's exactly what it's doing in the back of the eye.
Because those are the principal glial cells in the retina, and also works as those increase, it increases an antioxidant effect.
Exactly. Yeah. And this is why, I'm so kind of excited about this technology, and I've kind of kept it as part of my toolbox, since I graduated fellowship, almost, about 8 years ago. I see how it works. I understand how it works. I see that it works. I use it in my patients. I trust in it. And, anyone that I know that's a new, graduate, a retinal surgeon, a new graduate of a retinal fellowship, I talk to them about it. And I say, listen, you may not have had access to this in your training, but read about it, demo it if you have to. Find whatever company you think is you have a good relationship with, and have them bring it to your office and demo it and use it and keep it in your armamentarium. It's a great tool to have, and you really serve your patients well by making it available to them.
I actually printed out a paper on MicroPulse laser and gave it to one of my patients to bring with him to bring to his retina surgeon, because that's how effective this technology can be.
Yeah, absolutely. And I hope that whoever that retinal surgeon is, takes interest in it and says, you know what, let me give this a try. Let me demo it for a week or for a month, and they'll bring it to your office. A lot of these companies, they want to work with doctors, they'll let you demo it and you can use it. And, then you can start going into discussions at the meetings. They have little side, kind of a group specific discussions that you can go to, and you can talk with other retinal specialists, across the country that are using it. And, that's how you learn.
Let's turn our attention to diabetes, diabetic macular edema. There's some research that shows that it actually improves the foveal avascular zone. So with OCT angiography, and if you could talk a little bit about that, we'll see an expansion of the foveal avascular zone. We'll be losing some of the capillaries, but MicroPulse laser actually improves it somehow, and also and can decrease the number of microaneurysms.
Right. Yeah. So, what diabetes does is a couple of things. So how does diabetes damage the eye? So it does a couple of things. It causes those little blood vessels in and under the retina to become ischemic. And basically those little tiny capillaries start to close off and die. And it also causes blood vessels to become leaky. So it causes ischemia and leakage. And one of the devastating effects of having long-term diabetes is that in the back of the eye, it can cause ischemia right in the center of the macula. So the part of the eye that's the most important, the epicenter of the retina, that allows you to see clearly, you can see people's faces, you can see colors, you can see details. That's the area that it can damage. And those little blood vessels that feed, nutrients and blood to that part of the retina start to die off. And, for the most part, once those capillaries die off, and you can see that on a fluorescein angiogram, the right in the center of the macula, there'll be a big black area where there's no blood supply. And it tends to get bigger and bigger the more uncontrolled a diabetic patient is. And so the goal is to avoid that. And if it starts, we need to have very tight glycemic control of the diabetes. And now with a MicroPulse, there is some kind of rejuvenation. I mean, I don't want to oversell it and tell people that, if you have this MicroPulse, it's suddenly, you're going to regain your vision that you've lost, 10 years ago. But there is some level of retinal rejuvenation going on in the back of the eye that may improve some of your vision that you've lost from diabetes.
So there's been also some studies, and we talked about this before, that it also works almost as good as anti-VEGF injection, especially for the more severe non-proliferative diabetic retinopathy. So I guess they're doing studies. What have you found in your experience as far as comparing it with severe non-proliferative diabetic retinopathy compared to the anti-VEGF injections?
Yeah, so we originally started to work on this idea back in 2013, 2014. What we wanted to do is kind of do a head-to-head standard pan-retinal laser for a patient with proliferative diabetic retinopathy versus MicroPulse pan-retinal laser. So, in the entire periphery of the retina, you would laser a continuous wave, you would leave some scars, et cetera. And we wanted to compare it with a MicroPulse mode of it. And in the early studies that we did see there was some regression of the diabetes or the neovascularization on the MicroPulse patients, but not as good as the continuous wave laser patients. So that was in the early days that we're kind of testing out, comparing the two. And remember, this is not for macular edema. This is for proliferative diabetic retinopathy. Okay, so it's a lot more kind of an aggressive condition. And I can tell you just from personal experience that if somebody has profound neovascularization of the retina, horrible diabetic, didn't go to the eye doctor for 10, 20 years, finally got insurance or finally realized that their vision's declining, and they see, their ophthalmologist, their optometrist, and then they get referred to a retinal specialist. And I see that patient, the first fluorescein they've ever gotten in their life. They have tons of ischemia, tons of NVE. Those patients are better served initially treating with an anti-VEGF. And the reason is that even if you start them out with a PRP laser, if they have a lot of NVE, it will regress quickly after the laser, but then it bleeds. So then a week later, the patient's back in your chair. Maybe they're 20/60, now they're hand motion from a vitreous hemorrhage. And so they're wondering, what did you do to me? At least I could see. Now you did some laser, now I can't see. And so I can tell you from experience, it's probably better. These patients that are very, very high risk PDR patients, it's better to give them an anti-VEGF injection, cool down the NVE a little bit, and then do the PRP laser a week later, a month later. So the combination of the two works well. Or you can do anti-VEGF and then a MicroPulse. It just works better, the combination of the two, if the diabetes is very severe.
And how about with pre-proliferative diabetics?
Yeah, I don't treat and severe NPDR patients with pan-retinal laser, be it MicroPulse or standard.
Let's talk about vein occlusions, where these people tend to have very severe hyperpermeability of the blood vessels and seems to be more severe than some of the other conditions. How can MicroPulse be used for that, or is this a case where MicroPulse is not recommended?
You know, in my experience, I have noticed that these retinal vein occlusion patients, their edema tends to be very brittle. So it tends not to respond to laser that well as a sole treatment. So whether you do continuous laser, standard laser, or if you do MicroPulse, they just don't respond that well. They really need anti-VEGF. I think the VEGF load is quite high in those patients. And so they really respond best to anti-VEGF treatment. However, again, what happens if you're treating with anti-VEGF? You're treating them every 4 weeks. You're just slamming the eye every month with an injection, but the edema improves but doesn't resolve. Then what do you do? Okay, then you say, well, maybe I can use a steroid. What if the patient is phakic? And if you use a steroid, you're gonna, they're a trace NS cataract. Are you really gonna inject a steroid every 3 months in that eye? You know what it's gonna lead to? A pretty bad cataract. So in those cases, yes, you can use MicroPulse laser treatment in conjunction with the anti-VEGF, and you will see an improved response from the injections.
So in summary, if you could summarize the, central serous, early diabetes, diabetic macular edema, severe diabetes with the MicroPulse, if you could kind of give us a summary of it in conclusion of that.
Yeah, so, where I find MicroPulse really works the best is really central serous retinopathy patients who have diabetic macular edema, especially when you do a fluorescein and you see kind of diffuse leakage of the diabetic macular edema. Sometimes you'll get a fluorescein and you just see pinpoint microaneurysms. You can treat that with a standard laser. You don't always have to use a MicroPulse, especially if the microaneurysms are further away from the fovea. But in those patients where you do the fluorescein, and this again goes back to my point, why you need a fluorescein in patients, and you see kind of diffuse leakage, those patients, if you have diffuse leakage, you can't use standard laser. Where are you going to treat first? I mean, there's literally leakage everywhere. So those are the patients that you can use a MicroPulse laser in a diabetic macular edema patient. And then in the RVO patients, I like to use combination treatment as well. So the CSR tends to be heavily MicroPulse. The DME patients, combination, but slight tilt to MicroPulse sometimes. And then the RVO patients, you really do need the combination treatment to get the best response.
Let's turn our attention to some of the new technology in ophthalmology and retina, OCT angiography. If you could talk a little bit about that.
Yeah, so I just know a little bit about OCT angiography. I do know that, with a standard angiogram, you're injecting a dye in the body, and then the camera uses a certain filter to look at the flow of that dye through the retinal vasculature. OCT angiography uses the movement of the patient's red blood cells to look at the vasculature of the retina. And there's some benefits to that. Number one, you're not injecting a chemical in the body. So although rare, there's no risk of anaphylactic shock, nausea, vomiting, itching, et cetera, that you can get with a fluorescein angiogram. So there's that benefit of it. Second benefit is it actually gives you much more detailed information about some of the deeper plexus of blood vessels, the web of blood vessels that are within the retina and underneath the retina. So you get more detailed information. The question becomes, how do you use that extra information to your benefit clinically? And, OCT angiography has been around for a couple of years. It's yet to really make its way into the private practice world in a widespread fashion. It's been really mainly relegated to academic institution, and then of course a few private practice. But the clinically, from what I've seen, from the demo that I've had, from the information that I've read, I'm having a hard time figuring out how it's going to help me. become a better diagnostician from, relative to the imaging modalities that I already have in the clinic.
Let's talk about retinal holes. When should a retinal hole be treated?
Yeah. So there's an academic answer, and then there's the private practice answer. The academic answer is retinal holes don't need to be treated. We just leave them alone. What's the big deal? But I can tell you from personal experience of my own and many of my friends who are in the retinal community that there are plenty of retinal detachments that start from a retinal hole. You'll have a retinal detachment, you'll take the patient to the OR, and you'll say, okay, I'll just scleral depress them in the OR when the patient's numb and anesthetized and they're not feeling anything. And you're depressing and you're looking for the tear, and there is no tear. There's only one retinal hole, and it's because of that retinal hole that the retinal detachment happened, and now the patient is in the operating room getting surgery. So in private practice, most of the retinal specialists that I know, if they have a retinal hole, especially if the patient has symptoms, they have flashes, floaters, or they have a little bit of a cuff of subretinal fluid around it, they will go ahead and laser it. Now, if it's atrophic, looks like it's been there for decades, you can probably leave it alone. But symptoms and a cuff of subretinal fluid, my preference is to treat it.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
And how about lattice degeneration? Is there ever a time when you would treat lattice degeneration?
I use the same criteria. If the patient has symptoms that are high myope, they've had a retinal detachment in the fellow eye, or I can clearly see that there's vitreous traction on the lattice. When you examine the retina and you put the lens on the eye and you focus in on the retina, if you just pull back a little bit, you can start to see some of the details of the vitreous. And if you start to see traction, you can see that there's traction on that lattice. I like to treat that patient with prophylactic laser 360 degrees around the lattice.
And let's talk about macular degeneration. What's new in the treatment of macular degeneration and the different anti-VEGF injections? Do you find a difference between them?
Yeah, so when it comes to these injections, initially, they came out with Avastin and then Lucentis, made by the same company, Genentech, Lucentis being FDA approved. They work very similarly, the two of them. Then Eylea came out, which is by Regeneron. And, they basically block different receptors. Some of them block multiple receptors. And so they kind of work better, such as Eylea. And in my experience, Eylea does work better than the Avastin and the Lucentis. But we usually don't start with Eylea because Eylea is pretty expensive. It's almost $2,000 an injection, as is Lucentis. My preference in most patients is to start with a $75 Avastin injection. And if it doesn't work after a few injections, then we can, go up to the next level, injection such as an Eylea. That was the answer for the last decade or more. About a year and a half ago, Novartis came out with a drug called Beovu. And in the studies, it seemed to work better than the Eylea. But the problem was, once the drug came into market and thousands of patients were getting injected with the Beovu, we started to see some cases of catastrophic ischemic vasculitis in the retina, where the patient would get an injection a day later, a week later, or 2 weeks later, they would have immediate loss of vision in that eye, total loss of vision, and it was irreversible. And so because of that, a lot of retinal specialists pulled back from using Beovu. And think about it, we waited a decade since Eylea came out for another injection to come out. And finally we get one, we're all so excited, and it comes out of the gate, and then it starts to have this catastrophic issue. And now it's rare, but the fact that it can happen, it really makes a lot of retinal surgeons uneasy. So a lot of retinal specialists kind of pulled back on using it, and they use it very sparingly, if at all. I use it only in a case-by-case basis, the Beovu. And a month and a half ago, another anti-VEGF agent got FDA approval called Vabysmo, which is also by Genentech. It's the same company that makes the Lucentis injection. And Vabysmo uses a slightly different kind of a chemical structure, works a little bit different than the Lucentis injection or the Eylea injection. And in the original 2 studies that they did, the Vabysmo required less injections. And so what they did is they did 4 injections a month apart. And then after that, they went to every 2 months or maybe even every 3 months. after the initial 4 loading doses. So it seems to work better than the other injections. And I just started using it, and I just used it on my first patient yesterday, and I'll let you know in about a month how she does.
Do you think there'll be a time where there'll be anti-VEGF drops?
It's hard to say. Based on what we know right now, the answer is no. But so many things, so many discoveries are made that seemed ridiculous 5-10 years ago, almost ludicrous, and then it becomes a standard of care 10 years later. So based on what we know now, the answer is no, because you can't get enough of the concentration of the VEGF into the eye, into the back of the eye, especially with just eye drops. So it seems the direction we're going is injections, intravitreal injections, but medicines that will last longer in the eye and require less and less injections over 1, 2, 3 year period.
You tell a patient they have to get an injection into their eye, they flip out over it. They get very nervous. Can you explain the procedure and whether or not, if there's any pain or side effects, and what patients who may be watching this to expect, what they can expect if they need that injection and how it's done?
Right. So, great question. Only because I do this on a daily basis. So I think about it all the time. And I've really, over the last decade, I've really perfected my preparation. Doing the injection the correct way really comes down to prep. It's all the stuff before the injection. If you do that well, it's gonna lead to a much better experience for the patient. So the way I usually start with a patient, I explain to them their condition. I explain to them their treatment options. I tell them that, in certain of these conditions that they're going to need an injection. For example, a patient with a central retinal vein occlusion. Here's your problem. Here's how we treat it. We need to do injections. Injections in the eye? Yes, sir. Yes, ma'am. Injections in the eye. But let me explain, and I tell them we numb the eye thoroughly. It's done in a very controlled fashion. Pain is not an issue at all. And, so the pain is not an issue, but we're going to need to do this in the beginning, at least on a monthly basis, until we get control of the situation, and then we'll try to wean you off. But pain is not an issue. We numb the eye thoroughly. The way I like to do the injections is I'll have my assistant, once we decided that I'm going to do an injection, I'll leave the room and go see another patient. Meanwhile, my assistant drops 3 drops of topical anesthetic, proparacaine, whatever we have in the office, usually proparacaine. 3 drops, a few minutes apart. After the 3rd drop or so, which at this point it's been at least five minutes or so, I will come in and do a subconjunctival injection of lidocaine. And right at the bottom part of the right outside of the limbus, kind of at that 6 o'clock position, I'll give a little bit of a lidocaine injection subconjunctival. And then I'll leave the room for 5 minutes, go see another few patients. And then while I'm gone, my assistant will prepare the injection. They'll open up a sterile glove set. I use sterile gloves, very important. Everything's sterile. Eyelid speculum, betadine will be ready to go. I use a TB syringe to mark, and then my injection medicine. And so I'll come in the room after I've left. The patient's been numbing the whole time. I'll come in, I'll lean the patient back in a chair. I'll put a speculum to hold the eyelid open. That keeps it under control. That way the patient doesn't have to worry about, what if I blink? Don't worry about it. The eyelids will be in full control. Put a speculum in the eye. And here's the main thing. That subconjunctival injection, I found, is the best way to numb the eye. Some retinal specialists like to use topical jelly. They'll put it on the eye, leave, come back, and then immediately inject. It doesn't penetrate deep enough. And I've had plenty of patients who have been elsewhere and they've transferred their care because they say, every time I get an injection, I jump out of my chair when I get the injection. And it never has to be that way. So the trick is the subconjunctival injection, waiting 5 minutes. And then I come in, put the speculum in. And the second trick is I use minimal betadine. In the old days, they would douse the eye, the eyelashes, all the way up to the eyebrow with betadine. Totally unnecessary. Betadine is super, super irritating to the eye. Even when you wash it out, it still lingers under the eyelid, and then it's extremely irritating. A couple of drops of betadine right at the inferior kind of fornix, right at the area where I'll be injecting. And I put the betadine in, and then I put my gloves on in the meantime, let the betadine work, and then I mark, and then I do the injection. And as soon as the injection is done, I wash the eye out with sterile water. thoroughly. I have the patient look all the way around. I wash the eye out with water and I take the speculum off, and that's it. They don't need antibiotic drops after the injections. They used to do that in the old days. Plenty of studies that said that's unnecessary. And rarely do they need any kind of artificial tears after the injection. So the way I do it, they get maximal comfort, minimal to zero pain with the injection, during the injection and after the injection.
Where you mark the spot, how do you know, what do you use to mark the spot to know that you're in the right place?
So I use a TB syringe without the needle. So that opening on a TB syringe is a perfect location where the pars plana is, where you can go in with a needle without either dinging the lens or hitting the retina if you go too far outside of it.
Excellent. I appreciate that. Thank you for that. Thank you for that. Let's talk about floaters. A lot of patients come in, they complain about floaters. If you could tell us about floaters, is there anything that can be done about it?
Yeah, this is another topic that's near and dear to my heart, because it affects so many patients. We have thousands of patients, all of us have seen over our careers, who come in and say, "Doc, can you do anything about these damn floaters in my eyes?" And, for years, the answer was no, you'll get used to it. They'll settle down to the bottom of the eye. The brain will get used to it, et cetera, et cetera. And that's really true for 90% of patients. That's still the right answer. Give it time. You'll get used to it. It'll move out of the way. But in about 10%, they don't get used to it. The floaters are numerous. They're in the way. Sometimes it's like a thumbprint, like just like a wiper blade that keeps coming across your vision. And in those cases, those floaters are not going away. And so in the last, 20 years, there's been a laser, a specific kind of YAG laser that you can use to kind of zap some of these floaters. But the YAG laser really works best on patients who have a specific Weiss ring in the back of the eye. If you look in the vitreous and you see strands and floaters and circles and everywhere moving across, that's not a good patient for a YAG laser. It's not going to work. So then what do you do? So the third option besides do nothing and YAG laser is vitrectomy, pars plana vitrectomy. And this was never an option 20, 30 years ago, because the vitrectomy devices that we use, the instruments we put in the eye, were 20 gauge. They're massive. You would have to suture them into the eye as you're doing surgery. And when you pull the instruments out, there would be a gaping hole in the eye. You'd then have to suture the holes in the eye. There was a much higher risk of retinal detachments, infections, et cetera. So no one ever in the right mind ever considered 20 gauge vitrectomy to remove floaters for patients, until our instruments got better. They went from 20 gauge to 23, meaning they got smaller. And from 23, they went to 25. And now they've gone from 25 plus to 27, which is just tiny. So our incisions, we put the instruments in, and when we're done with our surgery, we pull them out, and those incisions just self-seal on their own. So the risk of retinal detachments, the risk of infections is significantly less with the new modern instrumentation. And so now that's become really the go-to treatment for floaters in the back of the eyes. With one procedure, 15 minutes, 20 minutes, maybe half an hour, you can remove practically almost 100%, if not 100%, of the floaters in the back of a patient's eye.
And what are you replacing the vitreous with?
So when we do the surgery, there's constant fluid being injected in the eye, that's connected to the vitrectomy machine, just sterile, water. And when we're done with the surgery, we just leave the eye under fluid, and the eye just generates fluid, clear fluid, to replace the vitreous.
And how often will you do a vitrectomy for floaters? How often does that come up?
Well, early in my career, not that often, just here and there. If I just so happen to have a patient that said, "Hey, doc, I got floaters. Can you do something for me?" And then I would have the conversation with them. But, in the last 6 to 7 years, now that my colleagues have understood that this is an option that I offer in the practice, the referral community has begun to understand that this is an option for patients. It has become my number one, number two procedure in the operating room. I mean, it's crazy. If you look at my surgical sheet from 8 years ago, the kind of surgeries I was doing to now, it's starting to shift, and it's shifted dramatically to floater surgery. And, I used to spend 3 hours fixing a retinal detachment. I mean, just go to battle with the eye with membranes and scar tissue and putting the retina back and buckles. I mean, just complex surgery. And, you'd pat yourself on the back, but the patient would like, well, yeah, I went from seeing, your hand to maybe seeing your finger. I mean, it wasn't really that huge of a victory sometimes. But these floater patients, they are some of the happiest patients. It's the equivalent, I guess, of what LASIK is to the LASIK surgeon in terms of how much benefit the patient gets, immediate benefit. That's, this surgery is for the retinal surgeon.
And how many vitrectomies versus YAGs to treat floaters? What would you say the percentage is if you had to ballpark it?
The vitrectomy is gaining a lot of attention and favor in the last, especially in the last 3 to 5 years. It's being talked about in the retinal meetings. More and more retinal surgeons are realizing, maybe I should offer this to my patients because they're doing vitrectomies anyways for all sorts of other retinal conditions. So now they're saying, well, maybe I'll offer it to some of these patients. The YAG laser, not that commonly done. There are very, very few ophthalmologists in the US that offer YAG laser treatment for floaters. Part of it is, it was just, the technology wasn't there. And if there was, no one ever taught it in residency programs. So you really would have to use it, learn it on your own, basically, once you're in practice. And most YAG lasers are not coaxial YAG lasers. You really need a coaxial YAG laser to be able to treat floaters in the back of the eyes. So, and lastly, the efficacy of YAG lasers, like I said, it's all over the place. It's somewhere between 50 to 90%. So it's highly variable. So for those reasons, a lot of ophthalmologists just never really, adopted it in their practice.
And lastly, I want to ask you about choroidal nevises versus melanoma. When can you follow a choroidal nevis, and when do you have to decide, well, this is something we might have to send to oncology?
So the way I like to personally do it, I'm somewhat of a referral source for oncology patients, is I follow the criteria of the risk factors, written by the Shields, Dr. Shields from the Wills Eye Hospital. And, they have a list of risk factors that you look at when you're looking at a freckle to figure out, is this nevis malignant, pre-malignant, or is this just a benign lesion? If you see a patient for the first time and they have a 6 diameter massive nevis and it looks slightly elevated and it just looks a little funny to you, probably better off referring it to an oncologist, have them take a look at it. And if they say it's benign, you and the patient can sleep better at night. In my clinic, I look at the risk factors and I list them in the patient's chart. Proximity to the optic nerve. Does the patient have subretinal fluid? Yes or no. Orange pigment? Yes or no. Drusen, which is actually protective. Having drusen is a good sign. Do they have drusen on the nevis? Yes or no. Are there symptoms? Yes or no. So I'm looking, and is there elevation? Yes or no. And one of the ways I assess elevation is on my examination, but I also do B scan to see how elevated a nevis is in the back of the eye. And the more of those risk factors that they have, the higher the risk there is that this may be a melanoma, or it's going to transform into a melanoma. So if they have more than one risk factor, I keep a low threshold. I send them straight to the oncologist, have them take a look. And if they say it's fine, then I can just follow them in tandem with the oncologist.
So you use too fine small ocular melanoma. Is that the
That's right.
That's the mnemonic that you use. When you're using a B scan, the B scan won't show elevation unless there's 2 millimeters. Is that correct?
You can see some elevation on the B scan, but the one that I have allows you to measure the elevation. So I can always measure it and then, do serial B scans over a time period and be able to compare the two. But you can, depends on the B scan.
And if they're just flat, then you'll typically follow them. How often, if you're not going to refer them and you're going to follow them, they have one risk factor or no risk factors. How often will you see that patient?
Once a year.
Once a year, not every 6 months.
In the first visit, after the first visit, I'll do a 6 month just to make sure that nothing's changing. And if it's stable, after that, it's an annual examination.
Well, I want to thank Dr. Walid Mangal for joining me today. He's a wealth of information. People want to find out more about you. How can they do that?
So, you can go to floridavision.com. Our practice is in beautiful Southeast South Florida. We have 5 locations in West Palm, Jupiter, Stewart, and Port St. Lucie, Florida. And if you need to get in touch with me, you can email me at walid.mangal@floridavision.net, or you can just call me on my personal cell phone, 851-7502.
And is there anything that you wanted to say or that I might have left out about in this discussion?
I think we've covered all the bases. I mean, you asked some excellent questions.
Well, I want to again thank Dr. Mangal for joining me today. He's a wealth of information, and if you need retinal services and you're in South Florida, you know where to go. This is Dr. Kerry Gelb for Open Your Eyes. Thank you for joining us tonight.
I appreciate it. It's a great honor.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.